Let us continue the therapeutics of anti-epileptic drugs. Case 4. Radhi, 10-year-old, has history of 2 years brief seizures lasting for second, and the diagnosis was absent seizures. As we discussed before, the drug of choice is ethosuximide. What are the expected side effects of the drugs? Common side effects generally the dizziness, headache, nausea, vomiting, and the GI upsets are recorded. How can you monitor your patient's drug therapy? Yes, monitoring of therapy for anti-epileptic drugs is an important task. The monitoring plasma drug level is useful. The we can say therapeutic drug monitoring, the concentration of the drug into the blood is very important. Then avoid triggering factors like insomnia, insufficient diet, which can affect the anti-epileptic drugs effect. Sudden withdrawal of drugs should be avoided, as we know that if we the anti-epileptic drugs should not be withdraw suddenly. There may be chances of the more excessive seizures and the status epilepticus. Stop the treatment after free period of 2 to 3 or more year from the last seizure or fit with be sure with the investigations of neurological examination like normal EEG, 3 consecutive EEG with 1 month between each one should be normal to stop the drug therapy. And what are the alternative, we can say second line anti-epileptic drugs for this patient of absence seizure or petit seizures? The available drug is valproic acid and the clonazepam. Next case, a 26-year-old woman experiences complex partial and secondarily generalized tonic-clonic seizure. So this complex partial seizure leads to secondary generalized tonic-clonic seizure. She is taking phenytoin 400 milligram per day. She reports having 2 or 3 partial seizures and one generalized seizure every 3 to 4 months. Despite taking COCP, combined oral contraceptive pills, she just learned she is pregnant and her last menstrual period was 6 weeks ago. Now, as we discussed that this is the case of the drug-drug interaction, we have to avoid the simultaneously or concomitant administration of enzyme inducer anti-epileptic drugs like phenytoin with oral contraceptive pills or any other drugs which is metabolized by the same enzyme. What is the relationship between the patient's contraceptive failure and her anti-epileptic drug therapy? Because phenytoin is an enzyme inducer, it affects the combined oral contraceptive pill blood serum concentrations, and that's why the patient get pregnancy. Because phenytoin induces the enzyme, so oral contraceptive pills also metabolized by the same enzyme. Fast metabolism, fast clearance of the oral contraceptive pills from the body and not able to achieve maximum or optimum therapeutic level, and the drug is ineffective. What are the risk of teratogenic effect of her medications? And if the she is pregnant and she is taking phenytoin, she should know the pregnancy. The phenytoin has the pregnancy category D, that is the adverse abnormal effect to the fetus will occur: fetal Head-and-Toin syndrome and fetal bleeding. Fetal Head-and-Toin syndrome and the fetal bleedings may occur. Now, what is the Head-and-Toin syndrome? Because the phenytoin has the chemistry, as we discussed in the lecture, of the Head-and-Toin structure, and the adverse effect caused by the phenytoin is termed as Head-and-Toin syndrome, with the fetal abnormalities and the fetal bleeding if the woman use phenytoin during pregnancy. What steps might be taken to minimize this risk? The first one is she should replace the phenytoin gradually. She should stop the phenytoin gradually and replace with the another anti-epileptic drugs which are safe in the pregnancy. And if she is not able to control the seizures with another drug, she should consider vitamin K supplementation for 1 month before the birth to avoid the fatal bleeding. A 45-year-old man under medical treatment for recurrent grand mal seizures, and he is suffering from urinary tract infection. And for the urinary tract infection, ciprofloxacin was prescribed to him. Now, what is ciprofloxacin? Ciprofloxacin is from the category of the fluoroquinolones. So the question is, the patient is taking the patient of the seizure, and he is taking ciprofloxacin. Is the choice of ciprofloxacin is appropriate? No, because ciprofloxacin is a quinolone antibiotic associated with an approximately 1% risk of seizures. Ciprofloxacin is quinolone antibiotic associated with an approximately 1% risk of seizures, and patient is already having the seizures. So quinolone antibiotic are tough to inhibit membrane receptor binding of the GABA. So the patients of the epilepsy, the quinolone antibiotics like ciprofloxacin should be avoided because the risk of the seizure. And what is the suitable antimicrobial can be given to him? We can use other antibiotic for the urinary tract infection like the nitrofurantoin, trimethoprim sulfamethoxazole, we can say cotrimoxazole, and the beta lactam antibiotic including amoxicillin and augmentin. Next case, a 44-year-old man who suffers from partial epilepsy. An MRI scan shows a choroid cyst on the right temporal lobe. The bilateral hippocampal sclerosis seizures take the form of complex partial attack, and at night secondary generalization occur. He had trials of treatment with every single drug and almost every combinations. 6 months ago, he was taking 225 milligram of topiramate, and about 225 milligram of topiramate, he is not able to tolerate the dose more than 25 milligram. 400 milligram of phenytoin and levetiracetam was added and titrated up to 2000 milligram a day. The patient tried to discontinue phenytoin, at which time he had significant increase in seizure frequency when he tries to discontinue phenytoin, because the the phenytoin should be discontinued gradually, not suddenly. Seizures have almost completely been abolished, and he is only having occasional nocturnal events of the seizure. He is, however, complaining of drowsiness and periods of unsteadiness. So, this is a case of the drug drug interactions. The patient is taking three drugs now: topiramate to 225 milligram, 400 milligram of phenytoin, and levetiracetam is up to 2000 milligram. What is the proper plan to manage this case? The patient needs his drug regimen should be optimized. Abrupt or sudden withdrawal of phenytoin in epileptic patient may be precipitate status epilepticus. So that's why the patient should not discontinue the any anti-epileptic drug suddenly, should be gradually. Phenytoin decreases the level of topiramate by increasing metabolism. Phenytoin decreases the level of topiramate. So here the patient is taking phenytoin and topiramate, and this is the case of the drug-drug interaction. What happened? Phenytoin decreases the level of topiramate by increasing the metabolism of topiramate, as we seen in the previous case, because phenytoin is an enzyme inducer drug and it increases the metabolism of topiramate and increase the clearance rate of topiramate. Furthermore, topiramate may increase the serum phenytoin level. So both drug having interaction with each other, and that's why the patient is having the drowsiness and periods of unsteadiness. So it would therefore be more appropriate to discontinue topiramate gradually. We have to withdraw the topiramate gradually because the topiramate may increase the serum phenytoin level, and phenytoin also decrease the serum topiramate level, and this is the case of drug drug interactions. Case 8: a 28-year-old woman with history of early morning myoclonic jerks since age 14 years. At 16 years of age, she presented with her first generalized tonic-clonic convulsive seizures and was referred to hospital specialist who diagnosed juvenile myoclonic epilepsy. Juvenile at the childhood, myoclonic epilepsy, muscle contraction during the seizures. At that time, she was started on sodium valproate 1200 milligram, that is valproic acid. Within a few weeks, her seizures were totally controlled. However, she now wishes to start a family and is concerned about the effect of valproate on her body. This is the case of anti-epileptic drug and effect during pregnancy. Now she is now 28-year-old and she has the attack when she was 14 year, and drug is started when she was at 16-year-old. But now there is no seizures was seen in the case. No seizures was reported in the case. Why she has worried? Because she was taken sodium valproate, which is anti-epileptic drug, 1200 milligram in the past to control the myoclonic epilepsy. At that time, she has taken sodium valproate, but now there is no seizures reported currently. But we should know what is the effect of valproate on pregnancy. Valproate is having pregnancy category D. Abnormal fetal side effects was reported with the use of valproate. It may cause neural tube defect in the fetus, so should be avoided. What advice would you give her? The available evidence indicates sodium valproate is teratogenic, with the most common malformation reported being neural tube defect. But she had no seizure for over 5 years, and it must therefore be determined whether she still needs medication or not. To find whether she need medication or not, she need EEG. Consecutively, three EEG should be there to decide whether she need medication or not. The risk of recurrence is low since she has been fit free for well over 5 years. More than 5 years, there is no reported fit or seizures. But the other issue is the effect of pregnancy on her seizure threshold. As we know that there is some evidence that up to 20% of women may experience an increase the fits or seizures during pregnancy. The option that need to be considered include change of medication. So if she get the fits during pregnancy, the lamotrigine and the levetiracetam was found the same during pregnancy. So you should advise to take lamotrigine or levetiracetam when she experienced when she has the fit during pregnancy. And this is for your information, the types of the seizures and their characteristics. You can read it. I already discussed in the lectures. Thank you very much.